As we all know, the treatment of autistic is a matter of great concern to the families and also the focus of the society. Before moving on to the main body of this lecture, I want to say thank you to Miss Jiang for your support, for providing rich content and sharing the valuable experience in Shenzhen Baoan Maternity and Child Health Hospital with us. These are our social media, and we would thank you for your following. And our lecture will focus on the following 4 aspects, and we will explain it and discuss it with you one by one. So first is the definition of autism spectrum disorder. And as when the presentation is going on, I will call autism spectrum disorder just as ASD. And ASD is a kind of neurodevelopmental disorder that starts in the early stage of the development and is mainly characterized by 2 important manifestations. First, it is the continuous social interaction and social communication ability deficits. And then is the restricted and repetitive behavior. And a lot of the studies have shown that men are more likely to suffer from this disorder than girls. And it is a chronic lifelong disease course. And because it begins in childhood and continues into adolescence and adulthood, it is usually a chronic long course, which often seriously damages the social function of patients. And it is one of the most important diseases leading to children's mental disability and serious diseases burden. And the intelligence level of patients varies greatly, including those with deep impairment and those with outstanding skills. This is the diagnostic criteria for ASD in the American Diagnostic and Statistical Manual of Mental Disorders. And this diagnostic criteria can be dissembled into 5 aspects, A, B, C, D, E. And A and B are the main manifestations of social communication and social interaction. Deficits are restricted, repetitive patterns of behavioral interests or activities respectively. And C, D, and E are the characteristics of these manifestations. And ASD can only be diagnosed when there are positive symptoms in A and B at the same time, and the symptoms meet the characteristics of C, D, and E. In the first manifestation, it must have all 3 symptoms in this domain to be considered positive. And in terms of the repetitive patterns of behavioral, it must have 2 symptoms in this domain to be considered positive. And as you can see in this table shows the severity levels for ASD. And this severity is based on social communication, impairments, and restricted repetitive patterns of behavior. And there are some core symptoms, but for the ICD-11 and the DSM-5, they divided the core symptoms of ASD into 2 main manifestations. First is the persistent deficit in social interaction and social communication ability. And as for the communication in deficits, we can see that for the verbal communication, most children with ASD have speech retardation, even no language, and their speech comprehension and application ability are also impaired. And for some kids, that the development of nonverbal communication ability of those children are also impaired. And they often do not communicate with actions or gestures, such as nodding and shaking their heads. They lack rich and delicate facial expressions. And another important manifestation is that they have restricted and repetitive behavioral patterns, interests, or activities. First, they have a narrow range of interests and are very interested in or even obsessed with certain things or activities, like they may keep turn on and turn off the buttons. And the behavior is rigid and repetitive and may be fixed in some special and useless routines or rituals. And they may also have some strange behaviors, such as staring and fluttering with your hands in front of your eyes. And it may be overreactive or underreact to various sensory stimuli, such as paying too much attention to the smell, texture, and vibration of objects. And they also have other symptoms and comorbidities. In addition to those two main manifestations, they may also occur with other psychiatric symptoms, such as emotional instability, hyperreactive impulsivity, self-injury, and so on. And most patients suffer from other mental disorders, such as anxiety disorder, OCD, affective disorder, eating disorder, such as they may stick to some kinds of food. And some children have some somatic symptoms or somatic comorbidities, including cerebral palsy, epilepsy, and so on. And they may also have chromosomal abnormalities. And as for the ASD patients, ASD starts in the early stage of development, mostly within 36 months, which is 3 years old. And among them, about 2/3 of the children developed disease gradually after birth, and about 1/3 of the children have degenerative onset after 1 to 2 years of normal development. And there are many important factors in considering the pathogeny of the ASD. First, it is also the most important factor is the genetic factors, and the heritability is among 0.7 to 0.9, and hundreds of genes are related to ASD. At the same time, the epigenetic mechanism is also involved in this consequence, and the immune factors are also associated with ASD. And another important factor is the environmental factors, and it can increase individuals' risk of ASD, such as mother may be underweight or obese before pregnancy, and they may have a threatened abortion, and they may also take in some certain kind of drugs and exposure to environmental pollution. And the interaction between genetic factors and the environmental factors are also quite important to consider, and they may cause certain abnormal brain development in multiple brain areas, such as frontal lobe and temporal lobe and amygdala. And they may also have an abnormal functional connection of multiple brain networks, such as face processing network and so on. And some neurotransmitter systems or neuropeptides are also abnormal, resulting in impairment, development of individual face recognition, emotional recognition, and so on. And according to the 2016 National Child Health Survey of the United States, about 3% of them have been diagnosed with ASD. And in those kids who are diagnosed with ASD, 1/3 of them received no treatment at all. Since the mid-1980s, it has been shown an accelerated upward trend. It is now prevalent globally at an annual increase of 3.8%. And as for the clinical evaluation for ASD, for children with suspicious symptoms of autism spectrum disorder, the following examination and assessments are recommended. First, it is the physical nerve systems examination, mental examination, developmental level, and intelligence assessment. And it can be divided into two kinds to assess the developmental level of children and to evaluate the intelligence level of patients. And they may also have some laboratory examination, such as genetic, metabolic disease screening, thyroid function examination, and so on. Also have the EEG and brain imaging examination, such as MRI and CT. Also have some genetic examination. And for some other screening and diagnostic evaluation of ASD, we have commonly used screening scales including the CABS, ABS, MCHAT, and ASSQ, and so on. The diagnostic scales including and the latter two scales can only be used after systematic training and qualification. And ASD has certain treat principles. First, early diagnosis and early intervention are quite important. And generally speaking, children can carry out family intervention under the guidance of professionals before the age of 2. After the age of 2, they can undergo comprehensive system intervention involving the participation of hospitals, professional institutions, and families. And then use scientific and effective treatment methods to intervene. And at present, a variety of treatment methods have been used to treat ASD, but many treatment methods still lack of good evidence-based medical evidence or have been denied by follow-up studies. And therefore, it is necessary to fully understand the research status of various treatment methods and choose treatment methods with good evidence-based medical evidence to intervene. And then the intervention with comprehensive treatment methods. Children with ASD are not only suffer from developmental retardation, but also have abnormal emotional behaviors and may coexist with other mental diseases. Therefore, according to the specific situation of children, we should use a variety of treatment methods, such as education and training, behavioral therapy, drug therapy, and so on, to comprehensively and systematically intervene those children. And ASD is also a chronic and even lifelong disease. Therefore, we should adhere to long-term treatment and intervention so as to promote the development of patients' abilities in all aspects, improve their social function, adaptation, reduce family burden, and improve the quality of life of patients and their families. And there are four treatment therapies are used currently. And first is the educational rehabilitation. It is also the most important treatment and intervention methods for ASD. And the more evidence-based method is the function-oriented educational rehabilitation methods. And the education intervention technology under the development concept, including the floor time as shown in this picture, and relationship development intervention, and Denver model and early intervention Denver model, structured teaching, picture communication system, and so on. And the behavioral teaching technologies based on applied behavioral analysis. At present, the most evidence-based method can effectively improve the social adaptation and the life ability of children with autism spectrum disorder. Commonly used behavioral teaching technologies, including the discrete trial teaching, the DTT, serious behavioral teaching, and natural situation teaching. And for children with ASD, they may prone to have various challenging problem behaviors that affect themselves and others, such as self-injury, aggregation, and destructive behaviors. And those behavioral function evaluations should be performed first, and after understanding the background, function, and strengthening factors of problem behaviors, we should adopt corresponding behavioral correction methods and prevention strategies to reduce the problem behaviors that interfere with children's learning and life from more to less, from less to none. And usually the medication is not the first choice to treat ASD, but it may be used when educational rehabilitation doesn't work and those problem behaviors doesn't disappear. And for now, in 2018, the Autism Consensus Group has supporting the use of RTMS in the treatment of ASD, and they have issued an international consensus statement on the potential of RTMS. And for the second part, we will have some introduction to the application of TMS in ASD, and we will have some useful info. First, to understand how does TMS work, we should understand TMS first. And TMS is used a time-varying pulse magnetic field to penetrate the skull to form and induce electric field in the brain's neuron cells, and then generate induced current to act on the nervous system, causing a series of physiological and biochemical changes, thereby affecting brain metabolism and neuronal excitability to improve the treat mental and neurological diseases. And it is based on the principle of electrical magnetic induction, and the whole process is painless and non-invasive. It is safe and effective. For the mechanism of TMS, there are different manifestations concerning TMS, and it can help to modulate the excitability of cerebral cortex. It has a long-term cortical plasticity modulation, can change the cerebral blood flow and metabolism, and affect neurotransmitter secretion in brain tissue. And as for the mechanism of TMS, to affect the processing of information by the nervous system, including neuronal synaptic excitation, synaptic inhibition, and synaptic plasticity. And the LTP and LTD caused by the high or the low frequency of TMS are important manifestations of plasticity of synaptic function, and they are also the main basis for TMS to treat different diseases with different frequencies. And the long-term potentiation, which is the LTP, is caused by high-frequency stimulation, which is more than 5 Hz, and the calcium ions concentration is increased. Thus, the cortical excitability is improved. And we can also use a low-frequency stimulation, which is below 1 Hz, and the calcium ions concentration is decreased, and thus to decrease the cortical excitability, causing the long-term depression, which is the LTP-TD-like effect. And there are different manifestations concerning ASD, such as serotonin and other neurotransmitters, balance disorders, impaired structure and functional connections between different brain regions, and the cerebral cortical response caused by irrelevant visual stimuli is significant, enhanced, and prolonged, and the gamma oscillation activity is also abnormal. And many studies have also discussed about the possible mechanism of TMS in the treatment of ASD, and they have found that RTMS can help in modulating the electrical activities of various transmitters and different brain areas which may relate it to ASD. And the appropriate stimulation mode of RTMS can enhance the gamma oscillation activity and improve the excitation and inhibition rate. And this is the evidence-based medical evidence of TMS in the treatment of ASD. This is, as you can see in this figure, it is a literature review of RTMS in the treatment of ASD from 2016 to 2018. And the most studies use traditional RTMS protocols, and the goal of most studies is to stimulate the DLPFC. on both sides or in the left hemisphere using low-frequency stimulation, which is among 0.5 Hz to 1 Hz. And most studies were stimulated once a week or twice a week, but some studies performed daily treatment for 5 to 29 consecutive days. And except for some studies, most of the studies use traditional figure-of-8 coils. And the meta-analysis showed a significant but moderate effect on repetitive and stereotyped behaviors, social behavioral, and number of errors in executive function tasks, but not other outcomes. And this is another cases for the application of TMS in ASD. They have used RTMS. They have found that RTMS has a significant effect on ABC scale, which is the Autism Behavioral Checklist. And they have applied 32 children with low function autism, and 16 of them has joined the RTMS group and received RTMS treatment twice every week. And the remaining 16 children were divided into the waitlist group. And they use a figure-of-8 coil with a low frequency to stimulate the DLPFC. And they have found that comparing before and after RTMS, as you can see in this table, it was found that there were significant changes in participants' ABC scores, including social behavioral and the total score. And some studies also applied low-frequency RTMS to improve the executive function and behavior of children with ASD. And they have recruited 54 autistic patients with a mean age of 14 years old, and 27 of them were assigned to active 1 Hz TMS treatment, and another groups are concluded into the waitlist group. And they also use a figure-of-8 coil with a low frequency to stimulate the DLPFC. And the results has shown us that they have found a significant decrease in stereotype repetitive and restricted behavioral patterns following 18 sessions of bilateral RTMS. And the scores of the stereotypic behavioral scales and the retrostatistic and stimulus behavioral subscale in the RBSR scale, it decreased significantly, as you can see in this two table. And the score of irritability subscale in the ABC scale decreased significantly. And therefore, neuromodulation using low-frequency inhibitory RTMS improves executive functioning and behavioral in ASD. This is another study used the ITBS, and they have found that our ITBS appear to improve restricted, repetitive behaviors, compulsion, and neurocognitive functioning. And they have applied 15 sessions of ITBS, which has a excitability of the cortical cortex, and they were divided for 5 days, five days a week for 3 weeks, and to stimulate the right DLPFC. And they have found the treatment, as you can see in the results, the treatment with ITBS appeared to improve restricted, repetitive behavioral compulsions and neurocognitive functioning. And these are protocols from the literature reviewed by the therapeutic guidelines, and some of them we have mentioned in the actual cases. And then we will talk about the safety of TMS in children. And generally speaking, the safety is quite accepted by many studies, but we need to have a close discussion with you. And in October 2018, the consensus meeting promoted and supported by the IFCN proposed the 2020 Safety Application Guide of TMS. and they have recommended that it is safe to use single pass or paired pass TMS for children 2 years, and when applied with suitable hearing protection. And for children younger than 2 years, data about risk for acoustic injury are not available, and therefore specialized hearing protection may be required. In addition, for children aged 1 year and younger, due to the lack of safety data, it will be necessary to obtain TMS data on hearing safety first. And according to current research reports, the large number of children, including healthy children, now have undergone single pass TMS, paired pass TMS, and even RTMS, which also provides us reassurance for the safety of these technologies. And this is another study that collected data on the safety and tolerability of using TMS and TDCS, which are the non-invasive brain stimulation technologies, in a total of about 400 children from 2009 to 2018, and these children receive a total of more than 3.5 billion stimulations within a structured pediatric non-invasive brain stimulation program. And they have found that no serious adverse and standard non-invasive brain stimulation are safe and well tolerated in children. And for the seizures, which is causing the epilepsy, there was reported despite about more than 100 participants have brain injuries and has epilepsy before. And the headache found in these studies are mild and self-limiting, and it will disappear soon. And as for other symptoms, it is also transient and mild, and the tolerability improved over the time with side effects frequency decreasing by more than half. And another literature search was conducted through the PubMed to review all TMS studies involving children from 1985 to 2016, and the documented any adverse events. And the review identified 23 RTMS studies involving children patients, including a total of 230 children with central nervous system disorders and 76 children with epilepsy. And the mild adverse events were as follows. And these events are moderate and may disappear soon after the end of the TMS. And the risk of any adverse events during RTMS population is only 0.0378 per session for individuals with central nervous system disorders, and 0 per session for patients with epilepsy. And over the past 30 years, over 4,000 children with or without neuropsychiatric diseases have been involved in different TMS programs. And the induction of seizures appear to be quite rare, and most reported adverse events are benign. And overall, the risk of TMS appears to be similar to that in adults, which is quite safe and can be tolerated by most of the patients. And when TMS is given to children, it is necessary to strictly follow the contradictions of TMS. In addition, special attention should be paid to series of changes due to the development of children's central nervous system. And the following questions need to be considered. First is a closure of the fontanelle. And from the birth to about 18 months, and the fontanelle of most children is in an unclosed stage. So therefore, the possible safety problems caused by the above risks must be carefully considered in the treatment of process. And because the skull and its related external auditory canal are in development, children's external auditory canal is very small and narrow. Therefore, TMS has no effect on hearing, but in order to prevent the noise of mechanism operation, children's hearing has not been fully developed, it is recommended to use earplugs or other means of protections. And compared with the brains of elder children, a very significant feature of neonatal brains has higher cortical excitability and higher risks. So, in conclusion, considering these factors, children younger than 2 years old should use it with caution, and it is recommended to use it for children over 3 years old. And these are some contradictions and some possible AEs. And we may go over it quickly. And as you can see, the possibility of causing seizures is quite rare. And these are some precautions for the families, for also even the doctors to follow. And such as the operator needs to tell the patient the principal process and possible response of the diagnosis and treatment to eliminate their attention. And for some physical disabled patients, appropriate help needs to be provided. And for the children, they may help to protect their hearing functions, so wearing earplugs to protect hearings are important for some young kids. And wear a positioning cap to accurately select the stimulation site is also important, because children may have smaller size of head, and before the stimulation, we should remove all possible magnetic items such as credit cards, bank cards, magnetic card keys, and so on, and choose the appropriate position, sitting or lying position for the children. And as we all know that there are many TMS protocols has been applied in China, and we will share some most important and valuable experiences in some hospitals. As for the Shenzhen Baoan Maternal and Child Health Hospital, it is authoritative and has reached TMS clinical experiences, and they have more than 10 years of TMS treatment experience. There are approximately 100 outpatients that receive treatment in the Transcranial Magnetic Treatment Room every day. Among them, there are about 40 children with autism, accounting for about 2/3. And there are 3 TMS devices in the TMS treatment room, all of which are from YINGCHI, and the main treatment indications are ASD, developmental retardation, cerebral palsy, and ADHD. And these are some valuable conclusions shared by Miss Jiang. And first, it is the epidemiology. As you can see in this table, the prevalence is higher in men than in women. And for the diagnostic and treatment overall, as you can see in this table, the first diagnosis of autism was 2 to 3 years old, and the first treatment with RTMS was 3 to 4 years old. And the commonly used stimulation site are left DLPFC and right DLPFC, the left Broca area, left and right temporal lobe, right and left prefrontal cortex. And DLPFC is, of course, the most selected stimulation site among them. And Shenzhen YINGCHI technology also provides TMS and navigation products to support some activities and to let the technology light up their hope. And as you can see in this picture, they use a TMS and navigation systems to help treat the ASD in those special children. And it is hoped that the targeted TMS therapy technology based on personalized physical sign data of children with ASD can accurately treat ASD. And the application of TMS in ASD, especially for younger children, needs continuous exploration. And there are many hospitals in China are trying to apply this easy, painless therapy to help children. And we also expect that there will be more successful events of the application of TMS. Through these efforts, more families will benefit from it. So thanks a lot for your patience. If anyone has any questions, I'd be happy to open the discussion.